Sister Mary Rocklage is a professed member of the Sisters of Mercy and has spent her entire career working in the healthcare ministry. Initially trained as a nurse, Sister Rock soon earned a master's degree in health services administration. Her leadership career has included a decade as the president of St. John's Mercy Medical Center in St. Louis, after which she was elected to the leadership of the Sisters of Mercy, St. Louis Province. In the mid-'80s, she became the first president-CEO of the newly formed Sisters of Mercy Health System. Later, she became chair of the Sponsor Council of the Sisters of Mercy Health System, and then became Health Ministry Liaison. Sister Rock has served as board chair of the Catholic Healthcare Association and also of the American Hospital Association. The following are selections from an oral history interview of Sister Rock conducted in 2011.
Later on, when I was leader of the community, at that time we did psychological tests and we do all this testing for, is the woman capable of being, living in religious life? And I thought, well, if they did that for me, I probably wouldn't have gotten in here. So I went and I looked at my file. I thought, what did they say about me? And the interview said, someday, one-liner, someday Antoinette Rocklage will be a fit subject. And I don't know if that someday has come yet or not, but anyway, that's how I entered and went in. I came back 3 years later to finish the 3-year program. Nursing education off, I'll just comment that it's very different. Women and men are being educated to understand more fully how all the systems and everything work together. We were told that, but ours was a more practical, hands-on, that you can get in there and you can work today. The day I graduated, or anyone, you were ready to work on the floor. You knew how to run the floor. You knew how to do everything that was in there. Today you come with a lot more theory. They prepare you to be a leader. They prepare you to make independent judgments, which you eventually learn just by your own experience of being in there all the time. You could tell something. But they get very little experience within the health environment itself, unless it's changed. By most of them, if they're on the floor, quote unquote, 40 hours, that's about all they've had experience of before they're actually working an 8-hour shift. In the hospital, when we were in there, you put in 40 hours right off the bat. You could step right in. So there is still that hitch for us when now today, when nurses come out of a 4-year program, you really have to provide them. And if we don't, we are doing them an injustice, and they're not going to stay in healthcare in the acute setting unless there's a way to journey with them and help them get used to that fast pace. You know, you're on your feet going 40 hours a week. It's not in for a couple hours of clinical experience. So that is being addressed. But healthcare is so complicated today, the medications, everything they need to know. So more I think about it, and others are thinking about it, there needs to be some kind of a bridging internship. And then there's a friend of mine, Peggy Hewlett, who's been thinking in terms of there's a different way to educate nurses. Maybe a 2-year really solid basic. Then if you want to work an OB, then you take some time for OB rather than you go through every one of the clinicals, surgery, OB, psych, and everything in a crushed couple years period. Give them the really in-depth solid education with the experiences, and then bring in what I would call the specialty areas, even at the bachelor level. I don't know if they'll ever pull that off, but that would be ideal. That would be ideal. Well, Vatican II was a significant change for all religious, and not just for the religious, but Pope John the 23rd said we have to have an aggiornamento. Open the windows. Let some fresh air from the world come in, and let's give our fresh air back. So he asked everybody to take a look. And the great gift to religious is that we had to go back and say, who are we? Why are we? And the key thing is, how are we going to be? How are we going to live our lives together? And so in that process, within religious communities, and I'll speak about us, there was a lot of what I struggle. There were those that felt we shouldn't change anything, and there were those that say, throw everything out the window, start all over. So for me, I would say, for me and for most of us, we were in the middle. We were in that healthy tension, not rigidly one way or the other, and that's a healthy tension. And we went through a lot of processes, trying to say, who are we? How shall we be? For a simple thing, we had to learn how to communicate. And not, we know how to, but to say, prior to that, you did what you were told and you went where you were sent. And now we were adult women. So if you were asked to look at something, you did it with the leadership and you equally listened to one another. And it was most of the time a joint agreement. This is what we ought to do. This was much more mature. So for me, that was a real struggle back and forth. And I would say still yet for us, because right in 2005, at our chapter, the Sisters of Mercy United States, we said that we should enter into another reflection process. Mm-hmm. What does it mean to be a Sister of Mercy in the 21st century? It's just like in anything, let's take healthcare. You have to remember who you are, be real to that, but you also have to be relevant to the times. And you don't throw out what's real, but you certainly have to be relevant to be alive, otherwise you become a museum piece. Now the struggle we're having in the church now is there are, many feel we've gone too far. I think part of our problem, we didn't educate people as we went along, who we are and why we're doing it. There are some things we're probably doing that we need to change. But there are a variety of ways of forms of religious life. We don't all have to live it exactly the same. So Vatican II was a great gift from the church. When I was serving in administration, there was the decision by the mayor to close the city hospital, Max Starkloff, one of the hospitals, and that was started by an African-American doctor, and it had been the hospital for the African-American people. And I was asked to help with that study a bit, and so I went down to listen. I was asked to be a listener because the discussions were at a total stalemate. Even though Max Starkloff Hospital was not being used much, it was the symbol for the African-American people that this was their hospital, and he started it. Meeting with the people there, it was, I thought, we're passing in the night. We're trying to talk to them about this place isn't air-conditioned. It doesn't have any of this. We need to replace it with something else, or find, if there was another institution they could go to. But I thought, we're talking facts. They're talking from their heart. And we're taking something away from them. So that was a real struggle. Violence didn't come from that, but it really caused a rift within the city for quite a while. And I don't know how many years ago, they finally have revamped that building, that it's now housing for people, women and men and children in that area. But that was a very bitter argument. And a couple of the aldermen were African American. And so when I tried to talk to some of them, you're not hearing the facts. I finally decided I'm not hearing the feelings, but we could never bring that. I wasn't the sole one. Please don't take it that way. But I was asked to be on that. And that was a real learning for me. I can have all the data in the world, but I have to get under your skin. And if you're under your skin, you have to also understand the data so we can come together. But we never bridged that gap at that point. And it was very bitter, the closing of that building. Yeah, not that they didn't have care. They were going to, in a sense, get better care. But it was theirs. It was their symbol. And government was moving it away. In one sense, was a backside gift another gift of Vatican II. I shouldn't say backside, because in the past we always thought we owned and operated these things, the hospitals. And in Vatican II then, after Vatican II and sisters moved out of the corporate ministries, there was a real question among many, if there aren't sisters here, how can they be Catholic? We were identifying it with that versus, and also what we don't do. We don't do abortions, we don't do tubal ligations. Versus who are we and what do we stand for? And so, and why do we exist? So went back just like we did with religious communities to say, what is this ministry? And what it is, it's a work of the church carrying on Jesus' ministry. And when we as religious began anything we do, because we only haven't existed in the church, we carry on the ministry of the church. And so we steward it. We don't own it. And so what does that mean on our behalf as religious women? So began looking at that. What does it mean to sponsor? And that word really came when the religious in the United States began to separately incorporate their schools and their hospitals from the Religious Community Corporation. It used to be what I call the one-pot theory. They had one corporate entity. And because of litigiousness, in the United States, plus the need to identify where the assets really belong, etc., they separately incorporated. So then civil law here in the United States says, well, if this belongs to the community, and then ultimately, the church, in a sense, never takes the property. It is church property by virtue of our taking care of it. What do you call that? And so what they say, they came up with the word sponsorship, which means that the two ways I like to look at it, and I keep it much simpler this way, is to say that by sponsoring, we publicly proclaim that we will assure that the purpose, for example, that the Sisters of Mercy health system exists. Well, we are going to sustain and make sure that takes place. And how do we do that? By stewarding the resources accordingly. So there's the business part, and then there's the value part that we have to honor. So for sponsorship, what it means is that and this is a technical term, but I like more the relational one, is that for an entity to be considered sponsored, it has to be connected with what is called a authorized entity within the church. Canon law calls it a public juridic person. It's like a corporation. That we exist within the church. That's where our existence comes from. That was the religious community. Okay. And we have a relationship with an organized or an institutionalized ministry, the health ministry. Okay, and we have to do that. And what that require of us is that we make sure that we have, as I said, that we are faithful to the ministry, and we can account for that. That we have no one can change the bylaws or the articles of incorporation without our approval. That we also look at who's appointed on the boards. They're not self-perpetuating. Why? Because they don't have to be Catholic. You want to be sure that these women or men understand what they're about in making the decisions for this ministry. And then the fourth one, because those three deal with our spirit. The other two would deal that we cannot highly take on debt that over a certain amount because you're encumbering the value or the assets. So because it's considered church property at a certain level, the community's got to approve that or it's got to go to Rome. And we can't sell or get rid of anything over a certain limit, like a hospital, without approval. But if we do that, sell something, the money never comes to the community. It is used in the ministry because we don't own them. So it's a way of us assuring that the works of the church go forward in perpetuity by virtue of an entity that's recognized in the church and given that authority to do it on behalf of the church. So, as Staley was saying, what does that mean? Right in the past, it's always been sisters. It's because we were the Sisters of Mercy, recognized by the church. We're this corporate entity, and these are all the things we do, schools, hospitals. Well, we don't have them to do that anymore. And so for over the years, we have been preparing, because we ask ourselves this question in 99, 2000, should we continue to sponsor? And so we did a 6-weekend study, and we came up looking at everything. Yes, We even asked people, does it make a difference to you? We asked legislative people in the lobby, does it make any difference to you? From some it didn't. Others said, yes, it did. But after our prayerful reflection, we said, yes, we're called to do this still yet. Because we haven't prepared people to take it. So 5 of us were appointed as a sponsor council, and I chaired that. And our responsibility was to make sure that we prepared people, or not that we didn't do it, we put people in place, and that we kept an eye on the future of when do we need to make the change. And so around 2005, 2006, I did a study. How many sisters do we have? How long can we be in it yet? How well prepared are our lay people to take this over? And we've been working on it. Said now's the time to raise the question. Well, not all the sisters were happy, but we went through this whole process of looking at, well, early on we looked at, do we sell it? Do we co-sponsor it? Do we keep it the way it is? Or do we do something different? And that's why we had the sponsor council. That goes back early then. So we figured we had enough sisters, not a lot of us, that would be around for about 8 to 10 years, that we could still journey with those women and men. Board chair, for me, is someone who knows that he or she is there to create the environment where everyone is encouraged and feels free to speak. A board chair who comes well prepared, well-informed mind, but not a closed mind. And make sure that the board members do that, and assures that everyone has the ability to speak. No one can dominate the conversation. Deeply respectful for each person. And you have to know your board members too, who's reluctant to speak and who maybe talks too much, and how you can do that blend. Also, you have to have you have to be free enough to allow the leadership, like the CEO or whoever that is, to freedom to lead the conversation. He or she is the most known. I mean, should know about it more than anybody else. So it's a team effort. But the board chair, I think, has to have a sense of where the board is. For example, at AHA, the agenda sometimes we're so strong you just have to step back and say, wait a minute, let's be quiet for a while. Let's think of where we are. So a deep listening, well-informed, no closed mind, and then the freedom to present your opinion at the appropriate time. After you have to create the environment where they know when you're saying your opinion, it's just your opinion. You don't control it. And then if you sense there's uncomfortableness in the group, you say, we can't go any further than this. That's what I would say. Another way to say it is everybody on that board, as well as the staff, know that you deeply respect them. And that you are a man or woman of integrity, of word and deed, and you expect that from everybody else. And that the environment is one, I would say, of hospitality. Now, that's not everybody saying ha ha ho ho. If it's in a hospitable environment, no one should be afraid. And so in that environment, everybody can put things on the table. Why? Because I respect you, you respect me, and we're going to be women and men of integrity, of word and deed. Then you can move forward. And it could be, and there's a lot of healthy tension in that. But that to me is a board chair. It's not about an individual. The board chair is the chair of that body of governance and leadership, as that book now says, governance is leadership. And the role of leadership is to assure that the mission and the purpose of whatever it is supported and sustained and is the unifying force in the organization. That's leadership, and that's also then the role of governance. So it's not a controlling. It's a permeating, and it's an assuring and sustaining, and calling it forth from the people. Let's look at CHA or AHA. When we send out something, we talk to the individual hospital. The hospital ought to be doing this, the hospital ought to be doing that. We would be much better off saying the community of healthcare deliverers ought to be together to do this. And get, we're going to still compete, but not this bottom line cutthroat. Is there a way ever, and all the planning laws from way back when have called for this, but then the rules don't let us. How does a local area say, this is what we need? And we don't own healthcare. We steward it. These assets that we're stewarding really belong to the people who paid us for it. How do we pull this together for the benefit of the community? Not that we be number one. I think that's a real struggle for us. As we can think of ourselves as a community of caregivers, bonded together to get this done. I know Stark laws and all that, but there's got to be some way that we look at it differently. And maybe it has to come from the communities, the public, the people living there themselves to ask this of us. I think that's a real challenge. Okay, the plan or the proposal as it was passed, I'm glad it was passed. It's certainly not the perfect one. My disappointment in the whole thing is it never says that every woman, man, and every woman, man, and child in this country has a right to basic health care, basic comprehensive care. We don't say that. What we did, and we've done every time, we tinkered with the financing. We don't have a vision of what we want that financing to do. We don't say, this is our commitment, that women, men, and children will have access, not to everything, but to basic comprehensive care, which is prevention, treatment, follow-up, and appropriate rehab. If I want a heart transplant, that's something else maybe. That's not, I wouldn't call it ordinary. We've never said that. So until we have a vision that we agree on, we're never going to say how we're going to untangle all the financing. I'm very pleased with what's in it, that if we can pull it off, that the 34 million people will be covered. That hangs on how our financing is. Very disappointed in how we're treating the immigrants and people who don't have, but they expect us to take care of them, but there's no reimbursement for them. And the pushback, that makes me angry, I guess, because on both sides, but particularly those that are pushing back, from my vantage point, they haven't even read, thought about, or studied the implications of what has been said or voted on, nor the implications of it to say, if this we have, what are the implications and how do we address that rather than eliminating? To me, it was it's like someone saying, you can write any law you want to protect me, but don't write one that allows others to have it. I want to be totally protected myself. And that's not just in healthcare. That's, if you see all the laws, there can be no law that makes a claim on me. That's how we all fight. So I think we've made a good step forward. It's cumbersome. As they say, the devil's going to be in all the details. And the other problem is we are not a patient enough society to deal with it. And in 2 years, we're going to turn over another legislative body, and we're going to start all over. We don't even have a vision of what we want to pursue. It's so fragmented. I remember, this goes back when I was with AHA. We had a meeting. There were providers, insurance payers, ourselves, I think physicians, and I won't say his name, but one of the gentlemen, president of one of the major health insurance companies. And I remember leaning up and I saying, would you be willing to sit around the table where you are providing the insurance, we're a provider of health care, et cetera, and all the different disciplines are there. And we remain true to who we are. But we're all willing to change enough to provide an effective healthcare delivery system in this country. Would you come to such a meeting? He said, I'll think about it. We never had it. Never had it. It's got to start with us. I'll still remain an insurance company or a hospital healthcare provider, but I'm willing to change enough, still true to who I am, that we all can blend together to provide a unified health delivery system. I don't know. I don't know if we can ever pull that off. I still hope we can, you know. When I happened to serve with CHA, I chaired to start up as a task force for people who are poor. And then it's right when all these different proposals at that time were coming in for healthcare reform. And so we put together a multifaceted task force from all walks of healthcare and life. And we developed a set of principles by which to evaluate each one of those proposals as they came in to see which one we would support. You know, and we came up with even an outline of a plan. But of course it didn't go, we even had in there what we talk about now of a healthcare provider, a case manager for each person. This goes back in the 80s. But it didn't go anywhere because there was no place to put it at that time. You know, it all kind of died. But, you know, that's there's a whole set of principles that guided us to say, that would guide us as the proposals came down, how would we evaluate them against this set of principles? I don't know if we could ever devise that for the United States. What would the people want? Have we ever gone out and asked the people in the country, what are the principles that you think we ought to use to evaluate a healthcare reform proposal? That'd be interesting to hear what the people say. If you recall, when I said earlier that when I got my master's degree in health administration, I said I graduated, and I was told, well, you can't be an administrator. My assignment was help where needed. I think I've gone full circle. I have a title now, but I think that is my role right now, help where needed, within the whole health ministry. Wherever I can be of assistance or be called upon, I think that's what God has called me to do now, and that's my missioning as a Sister of Mercy. My title right now is Health Ministry Liaison. And I chair the Class A members of the sponsoring body, and I serve on that board. But as Health Ministry Liaison, it's like I'm a conduit to help keep, at the leadership level and other areas, a sense of who we are and what we're about. I'm not the only one, but I'm like the current wire for that. But also between the religious community and the health ministry. Like I had a conversation with the chair of the board today, how to keep the leadership of the board and others more informed of what the sisters are doing. So it's that linkage kind of thing. So it's a liaison role in that way. And in the future, I pray about that. I'm in good health. I don't want to be in the way. I want to know when it's time to go. So I know it's not too far in the future. And if I'm in good health, I would like to do, I think, direct service to women, men, and children who are poor. And now this sounds funny, and to the elderly. If I'm in good health, I'd be good with the elderly. I'd be one of them. I am one of them. You know, one last thing we say about the Sisters of Mercy, we try to say it, this is what I hope I'll do. We say, live fully, love deeply, give totally, and enjoy life immensely. And I hope that's something that can be done until death.